one of the biggest things I find is this hedonic substitution, transferring from processed food or substance use disorder to processed food, or from processed food to substance use. And that tells you how closely interlinked they are. And I'm going to talk a little bit more about this in the last 2 slides, because I think that we have a way out of this. We have a pretty good way. It's not a way that I recommend for everyone, but I think we've got a way out. Everybody has a historical context of the physiology of all of this, and we look at these reward pathways and how it affects the nucleus accumbens, and it's dopaminergic driven. I always tell patients that when they hear the word dopamine, they shouldn't think it's pure pleasure. They're not going to just go, oh, that's pure pleasure. They should understand that it's a learning mechanism. That dopamine is a preserved system for millions of years across multitudes of species, that when we get that dopamine release, it's the brain telling us that what we just did was a positive thing, and to do more of that. And it just so happens to be interpreted by humans as, oh, that was pleasurable. No, what it is your brain says, hey, that was nutritionally beneficial, or that activity was progenerative and reproductive, or that activity, whatever it was, is going to benefit this body. And so I want you to do more of that. And so that's something that I always try to reinforce with patients, because it gives them a different context of looking at dopamine as not just some magic substance that they have to get to. And there's a complex web between the amygdala and the nucleus accumbens and the ventral tegmental area, and its projections into the prefrontal cortex. There's a complex web of information going on. When you have food addiction, all of these centers are activated. But there's something important to keep in mind. When you're doing regular eating, it doesn't activate all these centers. When you're doing regular eating and it's not a craving-based eating, you're not getting the same activation. In fact, we can show it on functional MRI that when you just eat because you're hungry, you don't get the same dopaminergic response. You don't get the same emotional processing changes in your amygdala. You don't have the same ventral tegmental area changes. You don't activate the full reward pathway. You activate it to a very light degree, and nothing like you do on a craving. So I want to talk about GLP and GIPs, because I think that these are the drugs that are Ozempic and Mounjaro and things of that nature. And I don't really love using GLPs and GIPs. And GLPs they're glucagon-like peptides. We give them to patients who are diabetic or type 2 pre-diabetic. And what it does is it suppresses their desire to eat. And it works on a central area in the brain, and it also increases slightly insulin secretion, and it decreases gastric emptying. So it makes patients feel like they're full. It's the magic drug that all of these Hollywood types are using to lose tons of weight. And we've had systems that have been adjacent to this in the past. But there's something interesting. And we found this in our own clinic, and other people are also finding it. What it does is that it blocks your desire for cocaine, alcohol, nicotine, amphetamines, and food. In fact, I have patients who are cocaine addicts, historically, who came in on cocaine, who are also overweight, patients that are heavy users of alcohol, patients that were formerly heavy smokers, patients that have been on amphetamines, and all of a sudden, they don't have any desire for those drugs. In fact, such to the point where some of them become anhedonic. They have lassitude almost, going, I just don't really want to do that cocaine. And I don't want to eat that much, and I'm losing weight like crazy. And now the thing is, when they come off, if you haven't coached them and done the right thing, they'll bounce right back even harder than they came into you on. So that's the key element. I mean, these drugs, the GLP-1 likely is affecting the reward-related changes and is definitely affecting some of the nucleus accumbens, and likely is affecting some of the dopaminergic pathway or pathways adjacent to that. And there's a whole host of other pathways that are associated with that hedonic craving. And so that's actually our go-to drug when we now have patients that have type 2 diabetes, that are obese, but also have comorbidities of substance use disorder, and they've been on narcotics, they've been on cocaine, they've been on alcohol. I find it to be incredibly useful, but you have to keep in mind that the patient will get anhedonic, such to the point where you can trigger a major depression. And I think that is something that we will learn a lot more about over the next couple of years, because now the population is being exposed to these GLPs and the GIPs, and there's going to be a lot of people that will have experienced this. You have to be very careful. A lot of patients will not tell you that they're drinking 6 drinks a night, and all of a sudden you give them, and they were getting this processed food because they were drinking so much alcohol and it was reinforcing. You give them these drugs, they lose their desire, and all of a sudden they have a seizure because they're not drinking alcohol. So you have to be very careful in this new emerging world and take a detailed history of substance use, because especially some of the downers that people are on, they'll have very serious complications when they acutely come off. And then you also get a lot of shifts of sodium and potassium, and you can have a lot of cardiac defect. So these are things that we are very, very conscious of when we're in this field, because we know that there's more to it than just, give them an injection and they won't have to eat sugar anymore.